Good afternoon, everyone. My name is Larissa DeLuna with the American Heart Association. We're going to go ahead and get started with today's webinar. So welcome to the American Heart Association Stroke Webinar Series. These educational webinars are brought to you by the Southwest Affiliate Stroke Committee. In this series of webinars, all webinars will be at the last Wednesday of each month from now until May. So we encourage you to visit www.heart.org/SWA quality for a full list of our whole series. Today's webinar topics include preparing your hospital for door-in, door-out measurement and improving cath lab workflow. Before we get started, we would like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your lines by pressing *6 or type into the Q&A section of WebEx. Although this event is not CME or CE accredited, attendees will receive a certificate of participation for a proof of attendance. That, along with all slides and handouts, will be sent to attendees within 2 weeks of today's call. For more information about our webinars and to view a recording of today's webinar, you can visit heart.org/SWA quality. Our speakers for today are Laura Griffin with HCA Houston Healthcare and Dr. Amir Hassan with the University of Texas Rio Grande Valley and Valley Baptist Neuroscience Institute. So at this time, I'll go ahead and turn it over to Laura.
Hello, well, welcome everyone. And if you wouldn't mind going to slide number 2, I'd like to start with just telling you a little bit about myself. So my name is Laura Griffin. I'm a neurocritical care nurse practitioner by trade, and I currently hold the position as the Division Vice President of Neurosciences for HCA's Gulf Coast Division. My current role encompasses everything that touches the neuroscience patient, from the clinical quality to physician recruitment, programmatic development, and business operations. I'm honored to be talking with you all today. Today we will discuss how to prepare your hospital for the door-in, door-out metric for all stroke patients that are coming in through your emergency department. Next slide. During this presentation, we're going to discuss 3 key concepts. And the key concepts really are how to identify opportunities for parallel processes. You can never communicate enough. Communication will be key to the success of this. And then continual improvement is absolutely the goal. Next slide. I'm sure you're all aware that Joint Commission is now requiring the measurement of door-in, door-out times for all stroke certified centers. While you will see on the right that all types of stroke patients will be looked at separately, so you'll turn in different metrics for each one of them, but the concept really remains the same for all of them. It's my belief that if you stratify the process, it will only lead to confusion and to delays. So while you might have to document them separately, I really recommend that you have a single process and a single goal. Next slide. So what does it really mean, and why are we measuring door-in and door-out time? Well, there's been a lot of research studies that show that longer delays in transport can lead to worse outcomes for these patients, which has really caused a response from many organizations to try and decrease door-in, door-out times. And you can see a couple of comments here from the Brain Attack Coalition and another research study. So what is the Joint Commission really looking for when they're asking us to monitor these times? Well, as of today, it is really more of a process. They want to know that you're looking at the time, and the improvement noted is just that you have a decrease in the median value. I did go ahead and put the Joint Commission website for this particular metric up there for your review. But while Joint Commission really isn't saying that they expect you to meet a certain time frame, many organizations and many systems are looking to come up with a time-based goal. And some of those that are being suggested are 60 minutes for those who receive alteplase and 90 minutes for those who do not. Next slide. So I thought I'd start with sharing a pilot process that we did here in the HCA Gulf Coast area between 2 facilities in Houston. And this is our Conroe facility up on the screen. While this pilot did not stop only at door-in, door-out, that was really the critical factor in the process. So this particular pilot went from door-in to door-out to next facility all the way into the cath lab. So this is our Conroe Hospital, like I mentioned. It's a primary stroke center, and it's about 8 miles from the closest comprehensive stroke center, which is in a competing hospital system. We were initially approached by a local EMS provider asking if we would consider to do a door-in, door-out process for LVO patients or large vessel occlusion patients. similar to a previous pilot we had done as we were preparing to go on the path to trauma designation. And the proposal was based on the idea that we could get their patient in and out as quickly as possible to the comprehensive center, that our EMS partner would feel more comfortable stopping at our Conroe Primary Stroke Center instead of bypassing to the nearest comprehensive center. Next slide. This is our Kingwood Hospital. And so we discussed, should we go to the closest comprehensive center, which was, like I mentioned, about 8 miles away, rather than going to our next closest comprehensive center, which was in Kingwood, about 25 miles away. So to make that decision, we reviewed some previous transfer center records and tried to figure out how long it took our patients to get to the closest comprehensive versus to our own hospital. And we found that to transfer a patient to a competing hospital took more than an hour longer, even when the safe travel time was factored in. We also took a look at the consideration that where could we control more of the factors to decrease delays. And we decided that we could do that if we did it between our own two facilities. So we chose to extend the pilot to our Kingwood Comprehensive site, which again was about 25 miles away from Conroe. Next slide. So as we were getting ready for this request, it was really important that all of our teams got together and understood the factors that would influence success. And the 3 high-level factors that we really need to understand and knew that we needed to affect were, first, the sending hospital's clinical and operational processes, our EMS partnerships, and making sure there was timely response, and any of the transfer efficiencies, as well as the receiving hospital's collaboration. So the sending hospital's clinical operations and processes really started with evaluating the sending hospital's current door-to-needle and their LVO evaluation process, because it's crucial, as that part of the process makes up the bulk of the time in a door-in, door-out process. Because we, we use a standardized system, like a protocol for all of our hospitals, that work was pretty much already complete, so there wasn't as much about agreeing on how that was going to be done. However, we did analyze the process further to see where we could cut more time. And it would be really important for each of you to examine that process in detail, so identify opportunities to save time, because again, that's where the bulk of this door-in, door-out is going to come from. Then we took a look at our EMS partnership. So we had an EMS partner who was engaged and who actually asked for the process, so we knew we had buy-in. And it also was helpful that Conroe had really one major EMS agency that served the hospital. And I recognize it's not a luxury that all of the hospitals will have, so I suggest that you engage your EMS partners as early as possible. And finally, we needed to look at our transfer center processes as well as the receiving hospital's willingness to collaborate and expedite services. As you know, transferring a patient from one institution to another is a complex process, and having a better understanding can illuminate the obstacles that your team is going to need to overcome. And we'll discuss a little bit more about that as we go on. Next slide. So I do have to say that before you start down this path, you must have your door-to-needle process as efficient as possible. Because the door-to-needle process takes up most of the time for door-in, door-out. And while you're going to be stratifying this data for other types of stroke patients, it tends still to be the part that's the most complicated. So it's really important that you understand that without excellence in door-to-needle metrics, the process will be set up for failure. Streamlining this process is really paramount for success. So before we embarked on this pilot, we'd already been working on door-to-needle in our hospitals for 2 years. And I'm proud to say that in 2018, out of the 19 hospitals in the Gulf Coast Division, that we were #1 in the entire company for more than a year for door-to-needle. And these are some of our door-to-needle metrics. So on average, our door-to-needle time was about 42 minutes. And we were less than 60 minutes around 80% of the time. So you will want to really work to decrease this time as much as possible. Next slide. This is a visual timeline for the average door-in, door-out process for an ischemic stroke patient. And I'm highlighting the ischemic stroke because it's more complicated, as we just mentioned. Not to mention, you have to be able to also fit in an assessment for an LVO patient. So typically a door-in, door-out, typically a door-to-needle and an LVO evaluation process occurs somewhere in the first 60 minutes or so after the patient arrives. So it's pretty common practice that after that beginning time frame that you see there on the slide, that the next place is that piece will be completed before the transfer center is actually contacted. And then during that time, there's doctor-to-doctor calls and some regulatory responsibilities for transfer that have to be completed, as well as that's when the EMS is usually identified to find out who's the closest, how quick can they be there, and are they available to transport the patient. Now, once the patient is picked up by the EMS, at best, the time travel remains static. But in cities like Houston, it's greatly affected by travel, traffic, and weather conditions. So that time will likely be even a little bit longer and definitely won't be able to be manipulated to be shorter. Next slide. So in order to improve your door-in, door-out times, the processes that normally were previously sequential, likely sequential in your hospitals, they have to be done in tandem. Without parallel processes, it's going to be difficult to cut down time. As I mentioned, the travel time, for the most part, is static. Traffic and weather can play a part, but there's little to be done to save time during there. So the question really is, ask yourself, is there anything that I can do during the time that the patient is being transported that I didn't do before? And we identified that we could start the transfer process also much earlier than what we previously had been doing. And we knew that if we called the cath lab team before the patient had even left, that we were going to cut time when the patient finally got to the receiving hospital. Next slide. So you have to start with planning, and planning is probably one of the most important points in this entire process because you have to get buy-in and you have to make sure that you have all the end users at the table. So we knew we were going to start moving towards parallel processes, and we decided to plan around that concept. So these are some of the things that we took a look at. Obviously, I just mentioned stakeholder buy-in is paramount. And when I say stakeholders, that means everyone. That means not only the sending hospital and everyone that's involved in the door-to-needle process inside that hospital and the LVO assessment. So that's lab, that's pharmacy, that's radiology, that's all the nurses and the physicians who care for this patient. But then we also had to have buy-in by the EMS and even the sending hospital. They had to be willing to get the call earlier, take the patient with a little less information than previously they might have gotten. Then we had to find a process that was going to resonate with everyone. Now, in most hospitals, the thing that people do very well is the SEMI process. It's the other time-based treatment that we have. And normally, door-to-balloon is a pretty well-oiled machine in most hospitals. And so we worked from the premise of that. What would we do if this was a SEMI patient going from one hospital to the next? And that really resonated with everyone and really helped them focus on how important it was to go as fast as we could. And once we got everyone on board and we got the concept together, then we started to design that process. And we wanted to design it around the most impactful factors. And then we had to agree that once we knew what those were, we were going to measure them. And I'm going to share some of those with you on the next slide. But we also had to agree upon a process for standby. Now, this is where it's going to get tricky for most people who are listening to this call. Again, I had the luxury of having an EMS who was a single EMS company who also had the ability to stay while we evaluated the patient. Most places are going to have to call another EMS back in. That may be because they don't have enough trucks to stand by, or that may be because you have a contract with an EMS company to transport your patient after it's been dropped off the first time. So there is some work that needs to be done inside of that. And after this call, if any of you would like to reach out, I'm happy to help you with a little more detail on how to do that. But we were lucky enough in this case that we didn't have to do that. And then once you do get the EMS provider situation all packed down and really working forward, you have to make sure that you have end user feedback on the processes. And so a lot of times in stroke, we'll have a stroke committee and we'll talk about what those indicators were there. But this really was going to require that we had communication not only in a once a month, we had it multiple times, but we didn't just have it with the hospital who sent the patient. We had it with the EMS, and we had it with the receiving hospital, and we even followed up with our transfer center. Also, tons of education. You want to make sure that the staff understand at each one of those touch points what the responsibility is and what they can expect to happen. And a lot of transparency also so that they are going to know that they can get back to you with what didn't work right so that you can continue to adapt the process. And then before we finally decided to go live, we went ahead and we did a multi-center mock code. We partnered with a vendor who came in, and we had an actor who went from one hospital and went through the entire process to the other hospital, and even had an anatomical model that we could do a faux mechanical thrombectomy procedure. And that was incredibly helpful for them to be able to walk that process through multiple sites. Next page. So these are some of the things that we looked at. So anytime you start a new process, it's imperative that you evaluate the process steps to identify opportunities for improvement. I have to admit, I ask my stroke coordinators to really look at a lot when it comes to data. And this is an example of the critical steps that we outlined in the door-in, door-out process, but it's really not exhaustive, because inside of this, our door-to-needle process is equally as detailed. But I really wanted to just focus specifically on the most impactful factors here. That being said, I believe that we have to evaluate all factors because you have to identify the weak links. So I like to illustrate the concept to the stroke coordinators who work with me as a chain. If in the chain there's a lot of links, and maybe there's a couple of weak links that you don't know they're weak, maybe they're rusted and you can't see it, or they're just weak. And if you go into a process and you accidentally target the chain links that are strong, you can make the chain much weaker than when it started. So not using a targeted approach to really improving a process could be at best ineffective and really at worst detrimental. So it's really important that you look at all these factors. Next page. So this pilot went on for about 6 months. And during this time, we had 7 patients that required transfer for LVO. On this slide, I put a couple of key factors so that you could show how we improved. I went back and did a retrospective review of cases in 2017, and we found that our average door-in, door-out time was about 180 minutes. And through this process that I've kind of outlined for you, we were able to get our lowest time for door-in, door-out 46 minutes. In that particular patient, we were not only able to get our door-in, door-out time down to 46 minutes, but we were able to get the door-in to groin puncture at another hospital, again 25 miles away, at just under 120 minutes. So it should be noted, though, while we were successful, and you can see here at decreasing our time, that it wasn't very easy in order to do that, and it didn't always go smoothly. But the other thing you should note, if you look at it on the door-out times under alteplase and non-alteplase, you will notice that we were much faster in the patients who had alteplase than not. And as I mentioned earlier in the beginning of this talk, that they're looking at potentially having those who get alteplase having a longer time frame in order to get out of your hospital than those who do not. And so we really attributed this difference to the heavy push that we have for saving time on door to needle. I showed you some of our metrics at the beginning of the slide deck on how well we did with that. And so the staff was really used to moving very, very quickly when they thought that patient was going to need alteplase. But once the physician stated the patient was no longer a candidate for alteplase, we felt the staff maybe was a little less pressured to continue at the same pace as they were before, because that's the way it had previously been when you weren't pushing for door to needle, and now this patient potentially had no treatment, that they were not moving entirely at the same pace. But there was one other factor that contributed to the delay in the patients who did not get alteplase, and that was the increased involvement of the neurointerventionalist in the patients who were in the 6 to 24-hour window. So the way we set up this study is if the patient was under 6 hours, they had their NIH greater than 6, they got their CT, CTA, and once the radiologist read it, they automatically started to activate the process, and the neuroendovascularist really was just told to go to the cath lab. They really didn't have as much involvement at that particular point, but once you start adding in the extended window for mechanical thrombectomy, then there are some additional studies that must be done, and then they wanted to have a lot more input on whether or not that patient was a candidate. So that started to slow down the process a little bit for those outside of that, in that 6 to 24-hour window. Next slide. So even though we were able to show some significant improvements, it really didn't start out that way. It wasn't easy. And it required constant review and adaptation. but we were committed to having a debrief at both hospitals after every single door-in, door-out patient. That was really huge because that involved getting a lot of people on a WebEx within an hour or so after that happened to try and look at the process and how we could improve further. Also, we had accountability. We had assignments for people. They knew, often like a code, they knew what they were going to be responsible for going forward and how to report that data back. We went ahead and did a deep dive, not just a debrief, but we did essentially a small RCA on all door-in, door-out patients. That included the successes and those that didn't go as well. We made a point to be non-punitive so that everyone would feel transparent about saying what they thought wasn't working well so that we could improve. Then we made sure that we told the EMS how much we appreciated them being a partner and that we would start to activate that process based on pre-hospital assessment. So if they called the hospital and said that we believe this is an LVO positive patient, that we would activate and plan on a CT-CTA as quickly as possible based on their assessment in the field. We kept the EMS involved. We took them to CT. We offered them to go to the lab if they had time, and we communicated with them. And we communicated with them every step of the way. Not only the EMS who were bringing in the patient and talked to them the entire time that they were involved with us, but we made sure to get that information back to the paramedics in the station and to the lead paramedics and to the medical director of the EMS. We made sure to always say yes at our comprehensive stroke center. There was never a no and there wasn't a delay to wait. We went ahead and took that patient immediately. One of the things, though, that we found as we went halfway through this pilot is that we were having some difficulty getting family contact. So that was an improvement that we tried to work on. And so we made sure that the sending facility, when they called not only the transfer center, but they would actually fax over numbers for that patient and some demographics directly to the cath lab so that the physician who was on call, as he maybe was even driving, he could make a phone call to the family and do consent as much as possible. But if he couldn't get consent, this is obviously an emergency and that he can move forward with that. Again, we communicated to everyone. And then the next thing that was the most important was getting everyone to believe, to trust the process. Because some of the hiccups that we had were just that people didn't think it would work the way that we had planned it out. So maybe a few naysayers or people who weren't in 100% support. And we tried our best to limit that by having end-user feedback early on in the process. We took it all the way to the staff nurses and said, what's wrong with this? How can we improve it better? But we just had a few people who weren't sure about trusting the process. But the more that they trusted it and more everyone bought in, the better that it went forward. This pilot took a lot of resources and commitment, as you can imagine, and it can be difficult, even in a single hospital, getting two collaborating units to work together. And many of you probably have worked with an ED and an ICU, and sometimes just get them talk is difficult, or even getting the night shift and the day shift to really work together. But we had to get multiple departments in two hospitals to work together, and that really says a lot about their dedication to our patients. And it took a lot of communication. But we made sure that we celebrated the wins and that it was a priority for us because it really was such an undertaking. And I do recognize that we were blessed with one critical factor that not everyone's going to have, and that's a dedicated EMS provider who had the resources to stand by. Next slide. So some key takeaways is while decreasing your door-to-meal time will be difficult, if you can save time through parallel processes, everything's going to work much better. So ask yourself, when can you call the transfer center? How early can you do that? What can you do while that patient is being transported from one hospital to next? And can you activate people earlier in the process than what maybe you have done before? Also, communicate with everyone. Don't forget anyone, because when you're talking about so many different people in different departments, and doing different things, but if you don't get that information back to them, they can't make a successful change. And always, always strive to be better than what you were before. And just remember that while it's difficult, being open to innovative ideas while committing to the goal is going to lead to success. And in each and every success that you have, one of your patients is going to be touched by that benefit. So thank you all for giving me some of your time today, and I'd be happy to take questions.
Thank you, Laura. We'll go ahead and kick it over to Dr. Hassan, and we'll take questions at the end.
Sounds great. Thank you.
So if you have any questions, please make sure to type them into the Q&A section of WebEx, and we can address those at the end. Or if not, we can come up with *6 at the end of our webinar to address questions. So Dr. Hassan, you ready?
Hey, do you hear me?
Yes, sir. Go for it.
Okay. So today we're going to talk about the Angio Suite and how we developed this specialty process just to continually educate and standardize everything across our current workflow, and using technology and education, how we were able to significantly improve our door-to-recon time, and especially our CT to recon time, because that's more of our control, especially as endovascular doc, versus the door to CT. Unfortunately, we need a great ED to be able to help us with that, and they are improving, but we're still not where we want to be. So do I have control of the screen? Okay. So
I'll run them for you.
Disclaimers and disclosures. And so we all know stroke is the #1 cause of disability in the United States. It is the #5 killer. It was the #3 killer back in 2012 when I graduated. And we would like to take some of the credit for the decrease in death, especially in South Texas. The major thing here is, even though death has improved, we're still the #1 cause of disability. And there's a lot of data out there. I've seen everything between 25 and 40% of strokes are due to large vessel occlusion. So we truly believe endovascular has a lot to do with the improvement in mortality as well as function, but we haven't really seen it when it comes to long-term disability yet. Next slide. So one of the, actually you can, that last bullet point, we can just stress the point again. So one of the main things that we noticed was the key to improving outcomes is time, right? And if we can get patients faster to cath lab and recanalize faster, you will have better outcomes. And here's a patient who is a 45-year-old male firefighter, falls down next to his truck. His person, his colleagues and friends saw him fall, immediately put him in EMS ambulance and brought him to Valley Baptist. Found to have a right carotid terminus occlusion, as you can see here, and he had complete recanalization. On the next slide, we'll start going through some of the times, and as you can see, his onset time was 9:30, as documented by his friends. Hospital door was 9:55. CT was completed by 10:06. CPA bolus was given at 10:08. CT angiogram was completed at 10:15. He arrived to the biplane at 10:30. Groin puncture was at 10:48, and recanalization was 10:57. So his door to recon time was 62 minutes. Groin puncture to recanalization was 8 minutes, 37 seconds. Patient went home, NIH 0, modified Rankin 0, followed up with us. So we invited him. We actually do a red ball, like a black tie event every year on the second night of our symposium. And he came and, just as a stroke survivor, and making a difference in someone like this really wakes up not only just other physicians and throughout your hospital, non-neurology, non-stroke team members. It really opened their eyes, right? It's not just treating, yes, most patients who have a stroke are 70, 80-year-old retirees, especially here in South Texas, mostly Winter Texans. But when you have a 45-year-old male firefighter, he's going to make a difference, right? This is a patient who will go back to work. He did go back to work immediately and made a difference, right? Continues to save other people's lives. So it was really great to have him come to our red ball and give a few words. Next slide. Here's another case. This is a 72-year-old, right distal M1 occlusion, and had complete recanalization. And on next slide, you can see here the time. Onset time was 10:30. Hospital door time 12:43. CT time was 1:28. Biplane arrival 1:39. Groin puncture 1:50. Recanalization 1:55. So his door to recanalization was 72 minutes. In a patient who's 72 years old with an NI stroke score of 24. Groin puncture to recanalization was 4 minutes and 42 seconds. It is our personal best. He was discharged home, modified Rankin of 1. 90-day follow-up, modified Rankin of 0. So these are just two examples of cases, and the nice thing is we don't really care about the one time or the second time. We care about our average, right? We are pretty tough on ourselves, and we make sure that this is across the board for all of our patients. Next slide, please. So it all starts with recognition. One of the main reasons we created the Stroke Research and Education Foundation, which we work very closely with the AHA, we raise money and we do the 2-day symposium on South Padre Island. We do the black tie event to raise some more money from the public, and then what do we spend it on? Spanish PSAs on the radio, billboards with fast on the on the highways, of course. But the key was this year's focus was Spanish. And what did we notice? We noticed there's a trend. When I first got here, way too many patients come via private car. 30% of them actually only call EMS. The rest are coming by themselves. So this is a significant problem. We have a lot of data that does show if patients call 911, they get triage faster. They usually end up in the right place. Unfortunately, there's another stroke center down the street from us, and they usually end up transferring the patient to us. But that's just another hour delay of potential treatment. Now that place does do IV TPA, and if the patient has a minor stroke, or even if it is a large vessel occlusion, sometimes they open up TPA. So it's not that we're not saying they shouldn't go to primary stroke centers, but when we're both about a mile apart and a patient's RACE score is very high, you would expect them to just come straight for endovascular treatment. So one thing we were able to do aggressively over the last couple of years is the fast billboards and PSAs, like I said, and we have noticed a significant trend in patients coming to the hospital sooner. Next. I'm sure you've all seen this slide before. Pooja presented this data years ago, and it was stressed a lot again in 2013 when the negative trials came out. The typical ELVO patient loses about 2 million neurons a minute, and we want to try to save as much brain as possible. Next slide. So I always found this funny when rounding on a stroke unit, which I don't do as much, unfortunately, anymore, just around in their ICU or just the endovascular service, is that some of the attending physicians or admitting physicians would say, oh, there's only just a small spot on MRI. And that small dot on MRI is 2 million neurons. And just to give you an example, if you see on the screen, that one little spot is neurons potentially lost 1.9 million, ages the brain by about 3 weeks. Just to give you some perspective. Next slide. So this is another way I like to look at it. So it's not just about, time is brain, we're losing 2 million neurons, but look at it this way. 1 minute saved is equal to 1.8 days of extra healthy life when onset to treatment with IV TPA alone. 4.2 days of extra life, onset to treatment with endovascular. And if you look at the bottom, every 20-minute decrease in treatment delays the 3-month gain of disability-free life. So these are significant changes we're talking about. And that's why we always say minutes matter. Next slide. Next. So we know why early stroke treatment is important. We have a lot of data proving that the sooner you get IV TPA, specifically in the golden hour. I know there was a recent publication, I think last week, about even in large vessel occlusion, giving IV TPA in the golden hour does improve recanalization rate. Next. So when we looked at this years ago, we did a trend paper in stroke, and we started looking at NIS, the Nationwide Inpatient Sample Data Set. What we found is the national average is about 15 to 20% of patients actually come in with an acute ischemic stroke to your hospital within 3 hours of symptom onset and are TPA eligible. If you were able to increase the window to 6 hours, actually 30% of patients who come in are treatable. The national averages are much lower than that. Thankfully, they have significantly improved in the last 5 years. But as you can see, next slide. This is just the citation for the paper. Next slide. We published it back in 2012. So 2004 to 2009, you see there's a significant increase in mechanical thrombectomy from 0.1 to 0.6, but TPA goes from 1.2 to 3.4%. But what's sad is in 1996, only 2% of strokes are being treated with IV thrombolytics. Now think about that. That's a whole decade after the approval in the NINDS trial So it really was a slow process. And I give a lot of credit to Get With the Guidelines and getting hospitals to just really strive for that, Joint Commission, Primary Stroke Center designation, or be with the Get With the Guidelines and get the award. Really improve the use of IVTPA throughout the country. Next slide. So how do we get to that magic 30%? Next slide. Gunslingers. So next slide, you can see some of these faces you might recognize. These are just different interventional neurologists, radiologists, neurosurgeons, actually throughout the world. Next slide. These are some of the members of the Society of Vascular Interventional Neurology. And next slide. Or one of my very close friends, Shazim Hussein, is at Cleveland Clinic. You can just refer to him if you're close to him. Next slide. So as you can see here, the old trials were basically showing significant hemorrhage rates, poor favorable outcome percentages, even though sometimes recanalization was pretty good. So it was really about patient selection and whether or not we should be doing certain things like in IMS3, giving partial TPA and then giving the rest endovascular is nothing. It is basically something nobody today would do. Next slide. So criticisms of the infamous 3 negative trials, poor patient selection protocols. Next. Limited use of the newer generation devices. Only 28 of those patients had centrivers. And slow time. Just look at that. 124 minutes from imaging to puncture. I would have a heart attack in my hospital if from CT to groin stick was 2 hours. I mean, when CT to groin stick is an hour, I freak out. So things have come a long way since 2013, and even earlier. Obviously, this was presented in 2013. The data is from much earlier. So that's probably one of the most significant things that you could have changed in a trial, is just make sure that patients go quickly to Cath lab and get treatment as soon as possible. Next. So everything was going slow. For some of you who know me, I'm a car nut, so I just have to throw the picture of the Yugo in there. Next slide. Now, the other thing is, could we just have been amateur gunslingers? Were we experienced enough in mechanical thrombectomy in stroke procedures? So this is a picture of us when we were all fellows at the University of Minnesota. Next. So just hit next one more time. So what can we offer our patients? It's a work in progress, right? We have clear designated times for door to CT, door to physician evaluation, CT read, and door to needle. Now, it's really not defined for mechanical thrombectomy yet. There are some things coming through. I know Laura touched on them earlier. Door in, door out times, improving, door to groin stick or door to deployment of mechanical thrombectomy device was a real big thing today. Not today, a couple of weeks ago at ISC. So I think we are headed in that direction, but it's really not everywhere yet. Next slide. So here are the 5 positive trials. Again, I'm sure you've all seen this data. Significant improvement in recanalization, significant improvement in favorable treatment. I think Swift Prime was no study ever in the United States had ever showed 60% good outcomes post-treatment in stroke. So this was a significant difference in outcomes, decreased bleeding. So we knew we were onto something. Next slide. And for the naysayers, I told you so. So we had better study design, faster times, patient careful selection, and newer devices. But the key here is faster times, and that's what the rest of this presentation will focus on. Next slide. So here's just an image, a 3D caricature of what an MCA occlusion would look like. Just hit the next one. Then you get the red, which is the core, right? This is what we believe is infarcted tissue that is irreversibly damaged. And one more. And then you have the penumbra. So for those patients who do have penumbra, which most of them do, it's because usually they have good collateral. But if you don't treat them, if you don't elevate the blood pressure, if you don't take care of them appropriately, the whole tissue is going to be infarcted. So yes, I mean, Dawn opened our eyes, and so did Diffuse 3 about patients that are slow progressors. You do have a little bit more time with them, but the majority of patients did not meet Dawn or Diffuse 3 criteria. So you do need to move as fast as possible. And I don't want people to, I mean, this is one thing we really pushed with RED. They were like, oh, you guys can treat strokes up to 24 hours. And we're like, whoa, hold on 1 minute. We still want to treat every patient as soon as possible. We do not want you to wait. Everything should be rushed, just as if it was a TPA case. But now, if the patient comes in the door and he's, 12 hours last known well, yes, we do have potential treatment options for him. Next. So, biggest thing we did is speed things up. Next. So, this study on the STEP-C project looked at time to treatment and how it affected outcome in acute ischemic stroke patients getting mechanical thrombectomy. We looked at how we can improve every step of the stroke care pathway, and then we focused obviously on the things that were really in the endovascular team's control, which was from when the patient arrives at the cath lab until recanalization. The integrated program was developed and implemented at our Comprehensive Stroke Center. Obviously, the objective was to reduce time to treatment, and then we ended up looking at the 6-year impact of it and looking at actual stroke cases and their outcomes. Next. So here's Texas. Next. And here's the Rio Grande Valley. So we are in Harlingen, which is really in the middle between Brownsville and McCallum. I hope you guys can come visit us April 26th and 27th for our symposium on beautiful South Padre Island. But as of today, I have no idea where the wall is going to be, so we might become part of northern Mexico, which I'm okay with. I love our Mexican friends. So as you can see, our catchment area is about 1.2 to 1.35 million. We cover Cameron, Williston, and Hidalgo County. We actually get transfers from up north as Corpus Christi. Next. So this is a little bit about our program. We have a 566-bed hospital. We do about 1,100 neuro cases a year. We have been, even before the Dawn publication, we were doing over 100 mechanical thrombectomies. Sorry, I didn't update this slide. This was a slide deck that was presented at our SDIN meeting in November. So at the time, it was 128 cases. I think we ended the year almost 150 mechanical thrombectomies. We have 2 interventionalists, myself and Dr. Techley. We used to have 2 biplanes. We just had the 3rd one installed a couple weeks ago. So we have 3 biplanes and a single plane. And we've been part of multiple research studies, including the 2 biggest endovascular studies in the U.S. with Prime and Dull. Next. So the key to the STEP-C program was education. First thing we did is standardize the workflow, standardize devices, standardize technology, and we did that with our in-house educators and with our suppliers. We got with, for example, Medtronic, Stryker, Penumbra, Microvention. We got with GE, since we have GE biplanes. And we just created this education process and made sure that everything is standardized and automatic. Everybody knows what they're doing when it comes to a stroke. And it's a beautiful thing, to be honest. The other day, we have Biz alert system, and we've gotten a lot of our techs, ED, stroke coordinators, research staff. Everybody's on the alert system. So when it says elbow detected, first thing my staff asks me sometimes, hey doc, what side, left or right? That's all they need to know. They know that it's always the same guide catheter. It's the same microcatheter, same suction catheter. They get the device cart next to them just so that the deciding on which, stent retriever I want to use. Maybe we're putting the patient in a study, so we're going to use something else. But everything is standardized except one thing. If it's a right side occlusion, they're going to pull a 120 Bernstein diagnostic catheter to put inside the neuron max. If it's a left side, they're going to pull a Simmons. And that's it. That's the only thing they need to know. Everything else is standardized. We always keep a dry table ready to go, and everybody's very comfortable with it. Now, when it comes to the process, we divide the pathway. Everybody knows what their job is. We always either have 2 techs and a nurse or 2 nurses and a tech. It's always a team of 3 plus the operator. We don't have fellows. We don't have students. And everything's done in parallel. So that's how we're able to really speed things up. From a technology standpoint, they know that we have automated settings. They know the Hassan Techley protocols for stroke patients. They know what screen setup we want, what dosing. For us, it's always low dose, right? We do 1,100 cases a year. The last thing I want to do is turn into the Incredible Hulk and be green. So we really care about radiation. We do a lot of research on this, and we have a very low dose protocol, and it's more than good enough to be able to treat mechanical stroke with mechanical thrombectomy. Next slide. So as you can see here, there are 3 phases to this process. Phase 1, continuous basic training and customization of this workflow. And that's what we did the first month. Phase 2, every month for 6 months, advanced training and fine-tuning. Take every single person and make sure they understand the process. So we share cath lab with cardiac. So there's always a call team and a backup team. You might be with the tech who really doesn't do the neuro cases during the day. So you need to make sure that he is comfortable with this process. He knows which devices to pull, which setups to use. So we did a very good job of this the first 6 months. And then the phase 3 is ongoing regular optimization. You know, new catheters come out, Penumbra comes out with Jet 7, Medtronic comes out with the React, Stryker comes out with the Vector catheter, you know, Microvention, I think, got Sophia. So everybody has their thing. And that's one of the things we love. We work with everybody. We don't favor any single company. And because it's really, you know, competition innovates. And as something new comes out, we discuss it, we do some cases, and if we have to change the process, we do. Also, you have new staff members come on board. So then they have to do that, you know, advanced training and fine-tuning, and that's during the optimization phase. Next slide. So hit next. Okay, so this is basically our workflow. This is how we simplified it for our ED in order to get the patients as quickly as possible to us. Every patient 0 to 4 hours, 0 to 4.5, think IV TPA. NIH less than 6, admit the patient, NIH greater than or equal to 6, call us, and it's a possible endovascular the patient. Every patient over 4.5 hours, CT, CTA, CTP, and call. That's it. That's all they need to know. That's all they need to think about. Next slide. Now, this is probably the most important slide I have on this deck, because this really tells you how our team works in parallel and how everything is done. Assuming the setup is 2 techs and a nurse on call, you know, my first tech is setting up the room, prepping the patient, getting the table ready, getting devices ready. My second tech, retrieving patient data, starts recording. We have the Mac lab outside. Every single step of the way is recorded. We timestamp everything, and that way we can go back every month, neuroscience committee, and go through it. Okay, why did this case take, for example, an hour and a half? What happened here? Why did this patient come significantly delayed to cath lab? We look at everything from when the patient arrives through the door all the way to recanalization. The nurse is pulling drugs after she helps the patient get on the table and drape. I'm typically talking to family, consenting, or seeing if the patient is going to be a study candidate for one of the studies. Now, by the time I come in and scrub in, I'm positioning the table in the gantry. I'm usually moving the table by myself because the first tech is not even done prepping devices. That's how efficient you should be. Because he's got your guide catheter and your selection catheter ready. You know, stick the groin, get your access, you go up, select your vessel. That takes you a couple minutes. By then, he's finished, you know, putting your microcatheter, microwire in and getting everything else ready for you. By the time you do your first run, devices are ready. Your second tech outside is monitoring, continuing to record, you know, Dr. Hassan, Dr. Tekle, and your run of the carotid. Microcatheter selection, deployed recant time. You know, just every step of the way, everything is recorded. Every device that is put in is recorded. Nurses obviously can help pull additional devices if needed. If we decide we have to acutely stent, they'll pull, you know, the agrostat, the glycoprotein 2B3A. They'll pull in the heparin. They're getting us the device and distal embolic protector device. And if she's overwhelmed and given drugs, then the tech outside. He can step away from the computer, open some devices, and goes back out. It's been a very efficient system, and so far, as you'll see on the next few slides, data's been pretty good. Next slide. So this is just an example of the technology, how we automate everything, and how the person is typically monitoring outside the room. Next slide. Next. So we pulled data on 377 patients. 240 of them had large vessel occlusion in carotid or MCA. 41 had posterior circulation, and 96 were tandem lesions, either carotid and neck and distal, or MCA and carotid. Next. So obviously, we care about door to recanalization time. That is the key to improving outcomes, but you need to stamp everything. So we stamp everything in between, and we try to see how we can improve our setup times, and we try to see how we can improve our puncture to recanalization time. So the focus of the paper is the interventional time when the patient arrives at the cath lab, but we also do look at door to recant. Next. So as you can see here, 75% of the total intra-hospital time reduction is attributed to the interventional time. And that obviously is with this process, improving setup time, improving procedure time, and getting the patient to recanalize faster. Next slide. As you can see here, there's a significant trend down in the first 2 years, and then it kind of plateaus, which is what you want to see. You want to see that as you've turned over staff, as patients, whether they're complicated or not, really things stayed the same. So you really did optimize everything you could from the setup and the recanalization time, and any other improvements in door to recant were due to our wonderful ED and our stroke coordinator who really helped improve the processes on the front end. That's on the left side. On the right side, you can see, you know, the biggest drop was puncture recanalization time after setup time was improved, but at a certain point, you know, it's going to take at least 11, 12 minutes to set somebody up. You can't really make things move much faster than that. Next. So this was interesting. We expected a significant difference in groin puncture to recount time based on whether it was a posterior circulation like a basilar lesion, tandem lesions, or just your typical elbow. And surprisingly, they weren't that far off. And they all, across the board, improved, with a significant improvement in posterior circulation as well as tandem lesions, even bigger than your standard large vessel occlusion. Next. So this is another great slide. So on the left, as you can see here, significant improvement, and the trend is towards improved outcomes with modified Rankin 0 to 2. And on the right, it just shows it to you in a different way, where you have a trend from 33%, 34, 39, 41, 53, and then for 2 years, it's basically the same. 53% of patients at 90 days have a modified Rankin scale less than or equal to 2. Next. As you can see on the right side of this table, slide, 92 to 90% recolonization rate, pretty steady. Intervention time decreased, modified Rankin increased. So really, is it time or technique? And I think it really is a combination, right? It's the less time you spend messing around, the less time number of passes you're doing, less chance of dissection, you're probably going to end up with better outcome. And on top of that, the faster you get it open, you definitely end up with better outcome. Next slide. So in conclusion, we demonstrate over a 6-year period that this integrated interactive program allows you to standardize stroke endovascular treatment, significantly reducing peri-procedural time and improving clinical outcomes. And in our center, standardization of these processes generated the majority of the total time to treatment reduction. The program can't be a one-time initiative. It needs to be done continuously, and it is challenging to maintain these performances over time. We continue to improve the door to recount time by reducing the pre-interventional time. And next slide. Just wanted to give you guys an update on, so I chaired the SVIN meeting last year. This year I'm going to be chairing the fellows course there on November 20 to 23rd, 2019 in Atlanta, and our own symposium on South Padre Island, April 26th and 27th. The first day is totally focused on just acute ischemic stroke, everything from EMS triage to rehab. And then the second day focuses more on endovascular treatment for all the other diseases. Thank you very much for your time.
Thank you so much, Dr. Hassan. So we have about 5 minutes left. If anyone would like to come off mute and ask any questions, I'll also check the Q&A section of WebEx to see if we have any online questions. But if anyone would like to come off mute. Okay, I do have a couple of questions in the online queue. This one is for Laura. What is the process in Conroe for EMS to monitor the alteplase infusion for patients that are transferred to comprehensive stroke centers for EVT?
I think that's a really good question because I don't think all over Houston that's done as well as we'd like it to be, including our hospitals and competitors, as I'm one of the chair people for our local RAC, and we find that to be an issue. But this particular EMS is very passionate about stroke patients, primarily because the medical director's mother died from a stroke. So they do monitor patients, the same vital signs, essentially not as detailed of a neurologic exam every 15 minutes during the infusion of TPA.
Great, thank you. And another one, would you be willing to share your debrief and mini root cause templates for this process?
I would be happy to kind of talk it out. We didn't have a template per se. Instead, we got on the phone and allowed everyone to speak. I didn't want that piece to be as regimented as everything else that we did. I think you probably heard a lot of similarities between Dr. Hassan and myself with some of the things that we did that had to be very structured in order to decrease time. So that was the one place that I wanted people to feel free to speak up. So I wouldn't say that there was a template specifically, but if you email me, I'm happy to discuss with you kind of the process that we did on that.
Great, thank you. And Dr. Hassan, we have a question for you. Do you use anesthesia for your cases?
No. Our patients are done awake unless they were intubated on the field. Then obviously anesthesia will join the case, but otherwise it's just us maintaining sedation, local conscious sedation.
That's all the questions we have in the Q&A section of WebEx. Would anyone like to come off mute with *6 to ask a question? Just as a reminder, we'll be emailing the slides, any handouts, and a copy of your participation certificate in about 2 weeks, along with a link to a recording if you'd like to refer back to the presentation today. Let me see. I think we might have one more question that just came in. Just praising y'all's presentation. Just someone saying thank you and how fantastic this was. Any other questions? Again, *6 to unmute. Well, thank you to both of our presenters for taking the time today to be with us and to give this fantastic presentation. We appreciate taking your time away from your work. We know how valuable you both are. So thank you so much. Have a great rest of the day, everyone.
Thank you.
Thank you.